and Raymond for that sharing. We appreciate sharing your personal issue. Indeed, that demonstrates something very important about our module for today, that making a change isn't easy for any one of us. And therefore, we don't expect it's going to be easy for our clients either. For change to occur, there must be motivation. Just like Raymond has shared, our motivation is not the same all the time. Sometimes it's high and we are sure of what we want to do. Sometimes it goes to zero and we begin doubting what we want to do. And that's the same as it is for clients. And we are saying that motivation for change can affect whether clients will enter treatment. Sometimes they will enter because motivation is very high. Then halfway in the treatment, they want to drop out. Why? Because motivation fluctuates. Other times they remain in treatment, but they don't adhere to the specific strategy for change that we have negotiated with them. And so understanding that it is because of motivation will help us be more informed as we continue supporting their recovery. Now, we are noting that motivation, sometimes people thought that motivation is static, that if I say I want to change, I'm going to be motivated, and I should be motivated all the time. Even we parents, those of us who are parents, when our children tell us they want to do better at school, we are excited. And, you know, we want to see them doing better, studying more hours. We want to see them doing more activities, engaging their teachers more. But sometimes they will have zero motivation and we wonder what happened. And you promised me to work hard as your parent. It's because motivation is dynamic. It's not static. We also acknowledge that motivation is purposeful. You know, motivation is influenced by some goal that we want to achieve. Motivation is intentional. It's something that I will deliberately choose to do, you know, or focus on. It's also positive in the sense that it pushes us towards action or towards achieving something. And of course, it's changeable. That means that it can actually be changed. And I think that's the strength that we have as practitioners, to know that even when our clients come with zero motivation, there is something we can do to motivate them, because motivation is not, static. So we are acknowledging that motivation fluctuates over time in relation to different situations. It can go back and forth, especially when we have conflicting goals. So I can imagine that sometimes Raymond would be so motivated because he was convinced that that job was no longer meeting his initial expectations. But maybe other times he would go back and think, wait a minute, but this big job gives me a big pay, and I need that paycheck for my family. So is it my family? Is it my personal, aspirations? Again, the goals begin to conflict, so motivation goes up and about. It varies in intensity. And we are saying that when we are in doubt, we actually find that our motivation goes down. But when the doubts are resolved, that is when the intensity of the motivation rises, and then you get determined and you implement the change. And of course, it varies greatly among potential behavior changes. That's really to say that at any given time, we have different potential behavior changes, and you may discover that motivation for one potential behavior change is higher compared to another one. For example, if I want to change from using substances, my motivation may be lower than my motivation to keep the good friends that I have. That is a competing goal. So that's what we need to understand. Now, we have got both internal and external influences of motivation. Now, we're going to look at the internal influences. A good example is our personal emotional states. Sometimes I feel angry and the anger can motivate me to change. For example, when we are leaving jobs or changing jobs, sometimes we are angry at our bosses because of the policies that are changing. Sometimes we are frustrated by the way the bosses are treating us or the work environment. And those emotional states can actually influence our motivation for change. And the same way with our clients. Our life goals, sometimes our life goals change. Sometimes we find that when we are at certain ages in our lives, the things that we pursue, the big names, the big jobs, the big titles may not necessarily be the same. Even our clients' life goals will change. And as they change, motivation for change in terms of recovery could also fluctuate. Perceptions about risks and benefits of behaviors. Sometimes I have had clients tell me, I use cannabis because when I use cannabis, I can study longer. And therefore, you can see their perception of the benefit of that behavior are different from mine. And so sometimes our clients' motivation will depend on what are their perceptions. And so part of the psychoeducation we do is about influencing their perceptions to understand the risks and the behaviors that they may not necessarily know. And of course, cognitive appraisal of the situation. In other words, what does the person think about that situation? Do they think that situation is risky, or do they think it's funny? One time, a girl that used cannabis in the university told me that she thinks using cannabis gives her this feeling of feeling heroic. You see, now her appraisal of the situation is different from another person's, and all these appraisals can determine the power of motivation or the influence of motivation. Now, when we think about external influences, this is what is outside of the individual. We have the family, we have the friends. Sometimes you have families that support recovery. Sometimes you have families that use substances, so that rather than being a positive influence on motivation for change, they actually sustain their old behavior. Sometimes it's the situations and experiences. A person gets arrested, for example, when they have used a substance, and they decide that, you know what, that was a nasty experience, I don't want that again. That motivates them to change. And I do know one person who ever shared with us that what drove them to start changing from using substances is they were arrested and they were given the option of going to jail or going to treatment. That situation in itself motivated them to go into treatment. Community support or lack of it, you remember Morekwe shared with us about recovery capital. So sometimes the community recovery capital can actually be a positive influence for motivation. But at the same time, when it's lacking, like we did here in the last session, it can also bring down motivation. Now, I said that we are going to be thinking about change from the model of Prochaska and others. It's called the model of stages of change. It has got various stages. One of the stages about change, which is the first stage according to this model, is called pre-contemplation. To contemplate is to think about. So when we say the client is at pre-contemplation, we are saying that they are not yet thinking about change. They haven't begun thinking about change, possibly because they think it's not so bad anyway. Their perception of the benefits and risks is still things are not so bad. That is pre-contemplation. But as they begin to experience the consequences of the problem behavior, they may begin to think, maybe I need to change. And then we say they are contemplating when they are beginning to think about the change. And I'm sure that Raymond must have engaged in this a lot as he was weighing, do I resign or do I keep this job? What will my family say? What will, this and this do? That is contemplation. And I bet from there, he went on to think, now I need to prepare. And he has told us, he started informing the family. He started consulting with the friends and letting them know that he will be leaving. That is preparation. The same with our clients. Sometimes they will be preparing to enter some change. And it could be, for example, beginning to find out. So if I wanted to stop using, what should I do? They could even consult with friends. They could consult with colleagues. That's part of preparation. Action is about getting into the actual behaviors that bring about the change. They may start attending a treatment program. They may start attending a support group for change. These are all examples about being in the actual change process. Maintenance are the things that the client continues to do beyond active treatment. So they may have left active treatment, but they continue, for example, to attend support groups. They continue to make a call on the counselor or on the treatment provider to explain what they are doing. They continue to meet their recovery coach. All the things that they are doing towards sustaining their recovery is what we call maintenance. And termination is where the client has fully integrated their behavior. They've almost normalized their life without having to think too much about the change process. It's like it's now a normal part of their life. Now, sometimes the client may slip into any one of these stages. That is what we call recurrence. And so those are the stages of change according to this model. And there's an activity for us to do. To be able to do the activity, I will just expose you to activity so that you can get to see what it's about. And then we shall introduce ourselves to it. And then we shall do more in the discussion group. So in this activity, you're supposed to turn to resource page 4.1, and you're supposed to look at the stages of change that are there, which we have just discussed. And then you're supposed to create posters to illustrate characteristics of each of those stages, include interventions you would make to bring a client who is that stage towards change. And you're supposed to give examples using skits. So when you do this in your universities, make this actually a real life example. Let the students or the participants create the case studies, let them act out the skits to demonstrate each of these stages. Now, before we go to that, I just want to talk about the remaining slides and say that part of our responsibility as treatment providers is to enhance the client's motivation for change at each of these stages. Remember, we have said motivation is not static. The client may come to our treatment center with zero motivation. In fact, in the last class, someone shared how clients will be brought to us without any idea of where they are. They have no insight, they are psychotic, they come into your treatment center or treatment setting, and you begin working with them. Even as you stabilize them, the soonest that they are stable and can begin to engage, as you begin to engage, you begin motivation for change. We are saying you play a very critical role in doing that. We are also saying that clients need and use different kinds of motivational support depending on the stages of change that they are at. And we are going to see a bit of that. So we are now going to end that, and I'm going to share something different on the characteristics of each of these stages. So this is the resource page 4.1. I hope you can all see it. It has got bigger details about each of these stages. This is what the participants are supposed to use to be able to come up with case studies. As we have already said, you can see that the pre-contemplation stage is basically when the client is not considering any change. After all, they don't see any problem with their behavior. Many people may be complaining, but they themselves are not necessarily seeing a problem. One of the reasons why clients will stay in this stage for a long time is if people do not allow them to experience the consequences of their behavior. In one of the classes last time, we talked about enablers. An enabler covers the consequences or shields the client from the consequences of their behavior of using. So if you do that, your client is likely to remain, or your family member is likely to remain in the pre-contemplation stage, when they will really be saying, it isn't that bad. That is what pre-contemplation is about. And we are saying that people in the contemplation stage must raise their awareness before they can consider change. And part of what you can do as a treatment provider is to support families, to educate families on the need to bring awareness to the client of how their substance use is creating problems for themselves. And as they engage the family member with that reality, over time, the family member may begin to contemplate about change, which is the second stage. Now we are saying in contemplation, they become more aware, and substance use is actually a cause for concern. They begin to even see that it is affecting them in many ways, and they begin to identify some reasons for change, some need for change. And as we go on in this module, we are going to see some of the skills we can use, especially motivational interviewing skills, to build this capacity to move the client from pre-contemplation to contemplation. So at contemplation, they begin to think about it. They begin to say, I think I need to change. I think I need to quit this. I think I need to do something. Those are all examples of statements of contemplation. We have said in preparation, they begin to do something. They may begin to actually look for information. So part of what you can do in supporting a client in this stage is to offer information, is to strengthen their commitment to affirm what they're thinking about changing, to help them look at the pros and build into them so that they see the value of that, help them begin to set goals. That's part of what we can do in the preparation stage, and so on and so forth. Now, in the action stage, we have said they are actually in change. They have already chosen a strategy for change. For example, they may have decided I'm going to do an outpatient program. They may have decided I want to go into a residential treatment, and they are already in there. They may decide that they want to do a support group, to attend a support group as part of their recovery action. So the key thing is they're actually doing something. And you can see some timeframes have been given here on what we can use to decide whether a client is in action or is in contemplation. Then of course we've got maintenance. When we are saying here, already a lot of gain has been achieved in changing, but a lot of work has to be done to sustain that change. Remember in our last class, we said recovery is a long-term journey. You remember that road that was long and winding and looking lonely. Maintenance is about keeping your recovery within that long road to recovery. And therefore, in maintenance, this is where we want to be sure that the client is continuing with their support programs. The client is continuing with the recovery boosting, recovery support boosting, whether it's attending the mutual support groups, whether it is engaging the counselor, whether it's going for periodic checkup or calls, all this is part of maintenance. And of course, we've talked about recurrence, where we said it's where the client relapses or goes back to use. And we said that they can lapse, and a lapse doesn't necessarily have to go back to a full relapse, especially if we make an intervention. And we also said, you remember in the definition of addiction as a chronic relapsing disease, that clients can actually go back and forth in their recovery. And that doesn't mean they're not recovering, they're still recovering. We just need to continue building their motivation for change. So having said that, I want to give you just 3 small activities here, which I want you to think about and tell me what stages of change you think these clients are at. So when you give me 3 statements, very quickly you will tell me what stage you think each of these clients is at. So the first one, the client begins searching for information about treatment programs he can attend. So please give me the answer. What stage of change do you think that client is at? The first person to raise your hand, I will give you a chance. Has anybody raised their hand, or have you put in the chat? Okay, very good. You have put in the chat. Excellent. Preparation. Very good and correct. Thank you. Statement number 2, client continues attending his AA support meetings enthusiastically. What stage of change is that? Please let me see your charts. One person says action. Do you think it's action? Please take note of the word continues. Yes, many people have said maintenance. It is maintenance because of this word continues. Continues means he's been doing it. So he's continuing, that is maintenance. Thank you. And finally, client says, everyone's against me. I don't think I think anyone who drinks that. Client says, everyone is against me. I don't think I drink any more than anyone who drinks does. What stage of change is that? Yes, I can see it is pre-contemplation, pre-contemplation, pre-contemplation. Thank you very much. And we're going to do more of these case studies in our group discussion. So thank you very much. And I now hand it over to Morekwe. Thank you.
Evening, everybody. We are going to shift gear. Thank you, Beatrice, for such an elaborate presentation on motivation. We are now going to shift gear to module 5. Just share it. From the beginning. Module 5 provides an overview with regards to treatment of substance use disorders. It also provides a look at the different ways in which treatment is actually offered. It also covers principles of effective treatment. So now let's look at the objectives of this module. We are going to be looking at 4 ways in which we can actually look at treatment. We'll list, at least by the end, I'm hoping that we'll all list 6 principles of effective treatment and identify 3 ways these principles are currently incorporated in treatment areas in your different respective areas. There are, as I've already noted, a number of ways in which we can actually look at treatment. And these include setting, the setting in which the treatment is offered. It's one way to look at treatment. The intensity of treatment and the duration, that is how often is the treatment is offered, and the duration. Then another way to look at it is how the treatment is actually offered, because there are different ways in which treatment can be offered, and we'll shortly go into more details about these ways. And then we'll also look at components of treatment, which is another way to actually look at treatment. And then there's continuum of care and treatment models and practices. Now let's first look at settings. What are treatment settings? Treatment settings are or refers to where the treatment is actually provided. Treatment services can be provided in a variety of settings, including but not limited to the list that we have here, right? Number one is drop-in centers. What are drop-in centers? Drop-in centers are settings in which clients are normally not required to make a prior appointment when they come in for services. Then we have hospital-based inpatient treatment settings. Hospital-based inpatient treatment settings normally are settings or maybe separate units within a hospital where short-term treatment is offered, including detox. And then we have outpatient treatment settings. Outpatient treatment can be offered in a variety of settings, including the hospital itself. Sometimes we have hospitals where they offer both inpatient, where the person actually resides at the hospital for a short period of time, and then they come for treatment services while they are residing at home. We also have outpatient settings. An example of that could be a community mental health setting. It could also be in our communities where we have health clinics, or just general clinics, or psychological hospitals that offer outpatient treatment. Then we have the non-hospital residential setting. The non-hospital residential setting actually offers clients a living environment in which they are offered treatment. As compared to the hospital setting, the non-hospital residential setting actually typically does not necessarily have medical staff that is full-time. And these non-hospital residential settings normally require the clients that reside in that residence to actually have gone through detox. And I want to give us an opportunity for us just to think about where we come from, the different countries where we come from, and think about the type of settings that you have in your countries where treatment is offered. And so I'm going to ask us to just write in the chat, and then I'm kindly going to ask him just to read for us. You can just kindly just write the country, and then so that we know, like in Nigeria, what are some of the settings that you actually offer treatment. Kim?
Nothing yet.
Nothing yet, okay.
No, it takes a minute. In Nigeria, we have hospital settings.
Okay, you have hospital settings.
Sierra Leone, hospital-based.
Hospital-based.
Ghana has all four.
Oh, okay.
South Africa, all of the options are available. A couple more.
Very fortunate, some of you.
Yes. Egypt, we have government, hospital, residential, and outpatient, all of the services.
Thank you for sharing. It's clear that we come from different areas, and some, like I'm from Botswana, where we don't have all, but most of what we have are outpatient treatment settings, very limited, and a hospital inpatient treatment center. That actually is a psychiatric hospital where they just have a small unit to actually address SUD treatment. Another way to look at treatment, as I've already noted, is the intensity and duration. Intensity refers to how often treatment is actually provided to a client, and it differs as per the settings in which treatment is offered. And then duration refers to how long services are provided to the clients. Then the third way to look at treatment is how treatment is provided. There are a number of ways in which treatment can actually be provided. We have one-on-one with a counselor. One-on-one is typically an individual counseling session. We have a group with peers, which is group counseling. It could be group counseling or psychoeducation, depending on the menu of your treatment. We have family members being provided treatment. An example of that could be a family session, family counseling session. And these days, we do have technology-assisted care. And an example of technology-assisted care is phone-based counseling. We also have web-based counseling. And currently, because of the COVID, we've seen a surge in terms of telehealth, including what we are doing right now, Zoom, being used as technology to offer treatment for addiction. Now, just one person, I want to hear from Burundi, because I don't know whether we have somebody from Burundi. Do we have somebody from Burundi? Kim? To whether there are other methods of treatment or how they provide treatment. Sudan?
I don't think so. I'd have to get my list up and see who's from
Okay,
where.
so I thought we had somebody from Sudan. But yes, we do have different ways in which treatment can be offered. Another way to look at treatment is components of treatment. What is it? Components of treatment are the elements or the pieces of treatment. These include assessment, counseling, education, and other activities. Of course, the list is long. So I wanted to know from you colleagues the type of components of treatment that are offered in your settings. Two people, you can raise your hand for this one because I can't see you raising your hand. What are some of the components of treatment that are offered in your different settings? Fatima has raised her hand.
Fatima, you can unmute yourself.
What are the other components of treatment that are offered in your settings?
Yes, like you have highlighted, we do assessment, and we do counseling. Then in terms of education, we go out, to do public enlightenment, to educate the public. We go to outreach programs, to villages, to educate people about the dangers of using drugs or abusing drugs. Yeah.
So other activities, outreach programs. There are a number of components of treatment. They include detox. They include support groups. And the list is endless depending on the type of setting and depending on the duration of treatment. The next lens in terms of how you can actually view treatment is looking at continuum of care. Continuum of care refers to the treatment that one receives, as well as other services that a person receives over a long period of time, over time. It has to be very clear that continuum of care, when a person is in a treatment facility, when they leave, the type of services that they are provided is what is called continuum of care. And we are going to have more time actually expanding on this topic. Examples of continuum of care, as Fatima has outlined, outreaches actually could also form part of continuum of care. Treatment, other services over time, I've already said, And basically, continuum of care is post-treatment support. What are some examples of continuum of care? Examples of continuum of care in your settings. You can raise your hand to provide examples of continuum of care.
I don't know if Fatima's hand is raised again or if it's left over from last time.
Is everybody awake? What are other services post-treatment that we offer clients in our settings?
So you are getting answers on this chat.
Yes, I can, yeah. If they are writing, Kim, you can kindly just, yes.
Somebody unmute. See. Oh, Fatima?
Yes. I don't know. Hello, can you hear me?
Yes.
Yes. I don't know whether this is part of continuum of care, but you see, in my facility, after the patient has been discharged, when it comes back for follow-up, we do some kind of toxicology test, you know, like testing the urine to know whether the person is still using or not. I don't know whether this is a continuum of care.
Mm-hmm. Yes, continuum of care, you can look at it, what are some of the services that are provided after the person leaves your facility, right? So what is the continued care that they get? One could think of vocational skills training. That is a service. It's not necessarily specific, maybe probably to addiction, but it's other services that a person needs that actually also relates to recovery capital, if you think about it. So we know that some facilities, sometimes they do not offer continuum of care. They offer treatment and then you just come back. But with regards to what happens after you leave the facility, and that obviously different types of treatment centers. But thank you, Fatima, for your input. And then another way to look at treatment is treatment practices or models. This refers to specific theories and techniques that a professional uses actually to provide treatment for clients. So our treatment is guided by specific theories and techniques. There are a variety of theories, but what is important for us as addiction professionals is to pay attention more to evidence-based theories and techniques in our provision of treatment. An example of a theory is CBT, or cognitive behavioral therapy. Maybe other people can actually also provide insight in terms of the treatment models and practices that they employ in their settings. What are the other treatment models or practices that you employ in your different settings? You can share. You can share in the chat. These are specific theories and techniques that inform treatment provision.
You have a couple. You have brief intervention, Gestalt therapy.
Okay.
Motivational interviewing.
Okay. Yes, those are actually evidence. I'm glad that you are mentioning evidence-based theories and techniques or practices. Thank you. Let's move on. We do have an individual exercise that we will not be able to do, but I'm going to just briefly describe what we are supposed to do in this exercise. it outlines the different ways of looking at treatment, right, that we've just briefly discussed. And so you are going to look at the different ways of looking at treatment, and then looking at resource 5.2, which has a lot of information or extensive information regarding the ways in which you can look at treatment. And then you are going to just populate your thoughts in terms of the how part, the duration, the intensity, the setting, the models of intervention. So if, for example, like what you've been giving as examples, what are the models of intervention, looking at your settings, and then continuum of care, as well as the components of treatment that are offered in your different areas. So if I could move on to the next, we don't have a break, of course, to look at principles of effective treatment. The National Institute on Drug Abuse, NIDA, has developed basic principles of effective treatment. And the development of these principles was actually informed by extensive research on treatment research outcomes. And these principles have been used worldwide and have been used to develop treatment guidelines as well as standards. I want us to look at the different or the principles. When you get your manuals, there will be resource 5.3. I don't know in terms of the manuals that you have, what page it is, but it's resource 5.3. So I'm just going to move to the manual and share the principles so that we can read. So just give me a minute. So I'm just sharing with you the basic principles of effective drug treatment, as I've already highlighted. And I want us to actually pay more attention to these principles because they would aid in further understanding of principles of effective treatment. So the first principle is that no single treatment is appropriate for all individuals. And I would want somebody to read, probably because we have a bit of time, the second principle. Oh, okay, I can go ahead because your mics are muted. The second principle is treatment needs to be readily available because individuals who are addicted may have mixed feelings about entering treatment, taking advantage of opportunities when they are ready for treatment is crucial, right? Effective treatment attends to multiple needs of the individual, not just his or substance use. I think this speaks more to. Yes.
I'm sorry to interrupt. You're not sharing the screen, so if you're.
I'm not sharing the screen.
No, sorry. I'm waiting for it to pop up, but it hasn't popped up yet.
Oh, wait, okay. Wait. Okay, thank you for that, Kim. I thought I was sharing what's going on and on and on. Okay.
I thought maybe it was just behind you, but now it's.
No. Oh, okay.
There we go.
Okay. Sorry about that. Thank you, Kim. The first principle is no single treatment is appropriate. Yes?
It's all set. Yeah, you're good.
Oh, okay. So the first principle is that we have to know is that no single treatment is appropriate for all individuals. Of course, that is true because all individuals have different needs and therefore we cannot use one size to fit all. The other principle is that treatment needs to be readily available because individuals who have SUD have mixed feelings about entering treatment. As Beatrice mentioned, the level of motivation, if it's low and treatment is not there, you can only just imagine. So when you have a client that is probably in the preparation, the treatment has to be available in order for them to actually say, okay, I have one option of this type of treatment versus this other one. Effective treatment attends to multiple needs of an individual, not just his or her substance use. as we have already discussed previously, we understand that individuals, they come with different problems besides SUD sometimes, and therefore our treatment needs to actually attend to all the needs that a client comes in with. An individual's treatment and service plan must be assessed continually, very important, and modified as necessary to ensure that the plan meets the person's changing needs. As you've seen, even in terms of motivation, the level of motivation can decrease, and the stage in which stage of motivation that a person is at. And therefore, it means that the treatment plan has to address where the person is at, or the stage at where the person is at. Even in terms of recovery, so your treatment plan actually has to take cognizance of the fact that the person is at different levels of recovery. Remaining in treatment for an adequate time is critical for treatment effectiveness. That is principle 5. Principle 6, counseling, individual or group, and other behavioral therapies are critical components of effective treatment for addiction. So a combination of different modalities of therapies are crucial, in the sense that we have already mentioned that addiction is a family disease. So we are not only going to offer service for the person who is actually using substances, but the people that actually are also affected in one way or the other, that probably would provide support for that individual. And hence why we need to be providing both individual and group or even family therapy. Medication are an important element of treatment for many clients, especially combined with counseling and other behavioral therapies. I know previously we were talking more about pharmacology, and there was a lot of mention in terms of pharmacological interventions that people use in different settings and different countries. The effectiveness of pharmacology actually is with a combination of counseling and other behavioral therapies. Individuals who have addiction or abuse substances and have co-occurring mental disorders should receive integrated treatment for both disorders. So when somebody has a co-occurring disorders, we want to make sure that we attend to both the disorders, not only to put emphasis on the SUD. Because we understand that if you treat one and you leave the other, these disorders actually impact the presentation of symptoms and how the process of treatment and or recovery. Principle number 9, medical detoxification is only the first stage of addiction treatment, and by itself does little to change long-term substance use. It manages physical symptoms of withdrawal, but it does not address the cognitive issues or the psychological issues that we see being presented in addiction. Treatment does not need to be voluntary to be effective. In some countries, you have mandated treatment. I don't know whether some of us in different parts of Africa, you have mandated treatment, but I know in the US, we have mandated treatment where instead of going to jail or prison, you are mandated to participate in SUD treatment. Possible substance use during treatment must be monitored continuously. That is the 11th principle. And then 12 is that treatment programs should provide assessment for HIV, AIDS, hepatitis C, tuberculosis, and other infectious disease. This is because we have people that use injecting drugs, and that we understand that our clients have other challenges besides substance use. So there's need to provide comprehensive assessment for all the diseases and disorders. And then number 13, recovery from substance addiction can be a long-term process, frequently requires multiple episodes of treatment. We have already mentioned that addiction is a relapsing disease, and therefore the need for this long-term process and frequent episodes of treatment. So those are the principles that I wanted us to share so that we, moving forward into our discussion, we make reference to those principles. Besides the principles that have been developed by NADA, can we see the slide? Hello?
Nope, not yet.
Not yet, okay, so sorry about that. This is the last. Share. There's something in here.
Do you want me to share mine?
Oh, it's okay.
It's working.
Okay.
Yeah.
Okay. So we are on the slide. This is the last slide. Principles of drug dependence treatment. WHO and UNODC have also developed principles of drug treatment jointly. The principles by WHO and NODC are more comprehensive as compared to the ones that we've actually just read, but they are very similar. That is the most important. Now, looking at what we have covered so far, I want one person to actually come up with a quiz or 2 quiz questions, and then we can have our colleagues answer those 2 questions. One person come up with 2 questions and then ask our colleagues to answer the question.
Do you want them to write it in chat, or do you want them to raise their hands?
They can raise the hands just so that we save time.
Don't see anybody.
Two questions based on what you've learned so far. Okay, I don't know whether they're writing it on the chat.
Here's one on the chat.
Yes.
Here's a couple.
Yeah, we can read.
Yeah. Which is the most effective? I don't know if this is a quiz question. Which is the most effective treatment principle? That might be a question to you. So the question, the outline any 2 principles of treatment is one of the quiz questions.
Anyone? Yes, identify. Maybe we can take Loratos or take one question and then allow one person to answer. Outline 3 principles. Okay, this is gone.
Yeah, so one says 2 principles and one says 3 principles. So those are really the same. So we could just ask.
Do we have an answer? Do we have an answer to those questions by Dr. Rihanna and Lorato?
Right
Okay,
now.
the other questions are for me.
Yeah.
Can anybody outline 2 principles?
I think it just takes a moment for the typing.
That's an interesting one. Why is treatment availability an important principle of treatment?
So here's one, yes, detoxification, only the beginning.
Yes, we do have two. People are writing just one, but it's fine. Michael has detox is the only beginning of SUD. But Ola says one cap fits all. Okay, good. Or no treatment fits all. Treatment should be based on patient's needs. Treatment must be available. I think this one, it's a repeat, but it's important. Does not need to be voluntary to be effective. I think that's the other one that probably we need to also take heed of, that it doesn't need to be voluntary to be effective, because we always think that if a client does not want to go to treatment and they're mandated, they are less likely to actually engage in treatment. Thank you. Somebody says good day all, but we will end here. Thank you for your contributions. We will end here to let Dr. Moses to continue to module 6. Moses?
Can you share?
Yeah.
Okay.
Yes. Welcome again to another interesting presentation. I'm sure the course is getting more and more interesting, and we're learning a lot from each other. I'm going to share, we're starting with module 6 now. Can you see my slide?
No, we can't see the slide.
Pardon?
We can see your screen, but it's not the slides. It's me talking that you see.
Okay. It's raining torrentially in my place, and I hope that the rain doesn't affect my network. So, but I'll still attempt to share.
And if it doesn't work, I can share mine. I have it open.
Yeah. But I can see ICDDR here.
Yeah, that's me.
Sorry, I'm Is it coming up now?
No, it's not. Moses, why don't I go ahead and share my screen?
Yeah, please do so. Okay, thank you, Kim. We are going on to module 6 now, and which has to do with components of treatment at the continuum of care. We've listened to Beatrice and Morocco. For Module 6, the goals are this. One is to provide a comprehensive overview of the various components of effective treatment. And then secondly, to provide an opportunity for participants to understand the concept of continuum of care by applying it to a client. So,
we're on the right slides.
yes, okay.
Mm-hmm.
So, no, the one before this, please.
Whoops, sorry.
Before the first one. Okay. From Module 3, we try to define treatment, in our various ways, how it applies to our various practices. So I want one or two people to remind us about what treatment means to them. I want to get responses from you. What does treatment mean to you in your own place of practice? We know in Module 3 we attempted to define what treatment is, and we got various responses. So who can remind us? But one or two people can give us responses for what treatment is all about. You can type it in the chat. Okay, Fatima, thank you very much. You're very active. A complete process of seeking, what is it now?
Well-being.
Yeah. Yes. Thank you. And then treatment must be adjusted, no? Any other responses, please? We've got one. Any other response, please? What does treatment mean to you in your own practice or your own community? The process of regaining oneself. Thank you, Professor Ezewa. Okay. It means, I know different things to different people, but the central idea is virtually the same. And I think Professor Ezewa has summarized it a lot here, the process of regaining oneself. The continuum of care, let's go on and see what we have to discuss today. The whole range of services a client might receive directly from a treatment program or coordinated by the treatment program. Yes, some treatment programs are integrated, they are comprehensive because of resources available. You can have, maybe 75% of all the components of treatment, you might have them in a particular setting. But in some places, it's just a component of treatment that you might find. So they have to liaise with other services. For instance, some services can send a client for detoxification. I know some treatment centers around my city who send clients to me to detoxify. Then they go ahead to do the other, part of the treatment. But in our treatment setting, we have most, of the components, operating. So if you have the resources, you can have an integrated care amenities going on there. But if you are constrained by the resources available to you, then you can collaborate and liaise with other services, available, with the consent of the client, and then you can still achieve, the treatment outcome that you set out, to achieve. So, and it doesn't mean that every treatment program must have all the components, available. So that is the key thing there. So we are going to the objectives of Module 6. First one is to provide a general description of an effective continuum of care for SUDs. General description of an effective continuum. We say treatment must be effective, must be evidence-based. And then identify differences between screening and assessment. a lot of people who are into substance use disorders, treatment or prevention, just limit themselves to screening, because they just do like they just do screening and then just cancel or refer, but they don't go beyond that. And then also describe what the process of detoxification, is all about, and then the various options available, for detoxification. Detoxification simply means, the process of which you allow, the drug, to leave the system. And sometimes it might be, it might do it naturally, or allow the body to expel the drug naturally, or it may be assisted, detoxification with other medication, so that you prevent the withdrawal symptoms that might, go with the withdrawal of the drug. But it varies from place to place. For instance, if when we were talking about in our discussion, I know we're talking about detoxification for opioids, and Professor Tafera, gave us his own experience how he uses tramadol, for detoxification. But in other places, I suppose Kenya, they have methadone. They have the luxury of using methadone, to treat their clients. But in my own country, though methadone is available, but it's not given to us for use. No logistics yet. It's there in the store. But the government is working, to provide the logistics and then the distribution, so that we can use methadone for the detoxification. So we use, in my own city, we use dihydrocodeine for detoxification, and then we get a good result. So, but the detoxification too depends on the substance. Some might be benzodiazepines, some may be opioids, and some might be, alcohol. Okay, let's move on. So let's continue. Thank you, Kim. And then we'll also be able to define case management. Certainly not today, but this is part of Module 6. What case management is all about, how we can, coordinate all the services that are provided for a client. That's what case management, simply means. The coordination of all the services, various services that, are offered to a client. And then name and briefly describe at least 5 interventions typically offered in primary HCD treatment. And there are all kinds of interventions that can be offered. And I thought that some of them were mentioned earlier. And then name and briefly describe 4 types of groups often used in HCD treatment. There are lots of groups that are used in HCD treatment. We'll get to know them later. And then name and briefly describe the self-help, mutual help options available in the community or in the area. Some will have AA or Alcoholic Anonymous, some narcotic, Anonymous, and so on and so forth. And then also define what continuing care is all about. We've said earlier that the process of treatment involves many things. And it's not just a one-off thing. It's something that continues throughout the life of the individual. And when we begin the first process, from pre-treatment to treatment, what follows after? How do we take care of the client when he's in maintenance stage? So these are things that we will learn later. And then apply the concept of continuum of care by identifying an appropriate continuum for a client via a case study. So there are case studies that will come up later. Certainly not today, but they'll come up later, so that we see, based on the client, treatment is tailored to suit the individual. There is no one treatment that fits everyone, no. But you look at the individual's peculiar needs based on your assessment, and then you can now design a treatment that is tailored to meet, their needs. So we'll get to do that later. Okay, let's continue. 4 parts of a continuum of care. Here we have 4 parts of a continuum of care that are listed. And the first one is pre-treatment. We are going to learn many things. Sometimes we do some of these things, but we don't know the appropriate terminology. We just mix up things and we don't define them very clearly. But in this module, it gets to define, for us what, the various treatment components are, so that we are very conversant with them. And then we have primary treatment, we have case management, and then we have continuing care, including ongoing recovery and management. It's not that it has to be linear in all cases, but there are people or there are clients that may just come straight in the primary treatment and a phase. They don't go through the pre-treatment and other things. And but some will start from there. And then, as I said, primary treatment is the main treatment you give, for the disorder. But you have case management to coordinate every treatment from detoxification to maybe pharmacotherapy after the detoxification, in case the client has maybe a comorbid disorder. For instance, a client who comes with alcohol dependence, and then also maybe severely depressed, or somebody comes with cannabis use disorder and also suffer from schizophrenia. What do you do? So you treat, and you also have to cancel, and there's so many other things. Psychosocial treatment comes in, life skills, so on and so forth. You need somebody to be able to coordinate the services rendered, so that the client gets the best of the treatment and nothing is missed out. That is what case management is all about. And then continuing care. As I said, when the client is now, for instance, comes in as inpatient and is now undergoing treatment and is in maintenance stage, is being discharged, how do you sustain that recovery? What happens thereafter? So that's what continuing care, is all about. And then the recovery management. But there are components of pre-treatment. As I said, this defines them for us very clearly. Outreach. Earlier on, some people, Fatima, spoke about outreach as part of the components of treatment that they offer. Yes. Outreach, you reach out to maybe communities or groups that do not have maybe an established addiction treatment unit or center. So you reach out to such groups, and there are many groups that you can reach out to. For instance, in my own treatment setting, we try to reach out to the internally displaced person camps that are close to us, because you have a lot of people who are displaced as a result of all sorts of conflicts, and they cannot go back to their homes, or their homes are destroyed, and they live in camps. But some of them are already using substances, and some of them are using substances to cope with the adversity. So what do? But they don't have the luxury, of drug treatment services. So we reach out to them, as a group. We also, in my city, my center tries to reach out to those in the correctional services. We have general psychiatry, mental health services, but we try to reach out to them exclusively, in terms of addiction services or social use disorder treatment, to reach out to them. So, but there are community outreaches too, which we have done. We have tried to reach out to communities, in fact, in collaboration with other NGOs or treatment centers. We collaborate and reach out to rural communities, or to women groups, or sometimes to religious groups, so on and so forth, and even schools, and invite us. So these are outreaches to, or programs or activities to get them to know what this problem is all about, and they get them to be aware, give them enough knowledge, and also the steps that they can take. And sometimes you may even screen them, and then when you screen them, you are able to advise them on the next step they can take if they are willing to do so. I don't know. Can anyone please tell us what outreach programs you carry out in your own communities or your own environment? I want someone to share. I have shared mine. I want to hear from the participants. You can type in the chat or whatever.
Moses, I'm going to stop sharing and then try resharing because people aren't all seeing it properly.
Pardon?
People weren't seeing my screen properly, so I'm going to start sharing again.
Okay. So I want to get responses from them. Okay, school outreaches. Yes, I can see one school outreaches. Any other? Okay, drug-free clubs in rural schools. Very good. Any other? Peer outreach programs with storefronts, DIC, as well as caravan mobile services. Oh, that's great. Wonderful. And then motor park outreach. Yeah, great. So these are examples of outreaches that various treatment centers, can do. And it can be done by professionals, can be done by paraprofessionals, or even it can be peer support. Those in recovery can, learn how to reach out to, others. Then we have, sorry, no.
Sorry, I'm sorry, that's my fault.
Yeah. Next one.
Yes,
The next slide.
I'm frozen, hang on.
Okay, thank you, Kim. Screening and brief intervention. Yes, screening has to do with trying to find out if there's a problem at all, and then see how you can help at that moment. And many people or many groups or communities will want you to do your outreach and to help screen and also do some brief intervention. And I think in some of the drop-in centers, they can do this too. They can screen and they can also give some brief intervention. And then assessment and treatment planning. Assessment has to do with those who have like more severe cases, who have established drug use problems. You have to determine what the problem is and what is available, and then you plan the treatment for the client. So assessment is a more comprehensive and method than just screening. Kim, I'm waiting for the slide. Hello, Kim. Hello, Kim. The slide has gone off.
Have it.
Yes, can I have the next the slide again, please? Sorry, it's raining torrentially in my own place, and in fact, it's also affecting my network. So I have two networks, on now in case one fails, the other one goes on. When it rains heavily like that, my network here is not very good. So I hope you bear with me. Yes, I'm waiting for the slide, Kim.
So I have unstable internet. I'm losing that. So
Mine tree is not very stable here because of the rain, actually. So that's the problem.
Okay. No, you had the right thing open.
I've not seen anything yet.
Okay, so Kim, maybe I can try sharing my screen.
Yes, please try.
Yes, please
For
do.
your end.
So can you stop share? Can you stop share yours and I
Because-
try sharing mine? If you stop sharing yours, I could try sharing. Okay, please stop sharing yours. So can we try this one?
Okay, okay, okay. Yeah, I can see it now.
Is that where we are?
Okay, yeah. Thank you very much, Beatrice. Oh, no, no, the previous one. The previous slide. Okay. Then assessment and treatment planning, and then detoxification. We've, talked about what detoxification, entails. So these are components of pre-treatment planning. So when we're talking about pre-treatment, somebody may think, what is pre-treatment? You think maybe it's before the client gets to an established center. No, even the detoxification is an aspect of pre-treatment, because you can't get this in your multiple choice and they're asking you, say detoxification is an aspect of pre-treatment. You say no, but it's already in the treatment center. Why is it pre-treatment? But it's still a component of pre-treatment. Okay, next slide. Beatrice, thank you very much. Outreach definition: reaching out to build connections from one group or program to another. And it is a good thing wherever we are to be able to connect with other services, because you really get a service that can provide everything needed in a treatment program, 100%. So when we have such understanding and we reach out and collaborate, then we can liaise, with other services, so that whatever you're not able to offer in your own setting, the other service can offer, and they will work together, and that helps the clients and minimize the problems they tend to go through, particularly in a resource scarce country like ours. And then extension of services or assistance to persons or groups not previously served. For instance, I know that I have never had, an outreach to commercial sex workers. And then there's a particular subgroup in my own client that they call jungle. But you see, there are some people who are not really trained in addiction management. I've not done anything, treatment, any evidence-based program on treatment. But because of the passion they have, they'll be able to reach out to those people, and they're really helping. And we have decided to train some of them, and they are now referring patients to us, and that is really helping. Next slide, please. So STD outreach: organize efforts to identify and screen individuals who may have a problem with substance use. It's a straightforward thing, and it's helping. So what are the goals? Establish contact, build trust. If you don't build trust, because a lot of stigma, as we said earlier on, there's a lot of stigma, surrounding substance use. So if you don't build this trust, you may not be able to get the people out there to come and avail themselves of the services that you want to offer. And then develop relationships, provide needed healthcare linkages, and then engage individuals in SUD brief interventions or treatment. That makes it easier for the clients, and then it reduces the hurdles they have to cross in order to get treatment. Next slide, thank you. Okay, why outreach? Yes, it's necessary because many people who use substances see treatment program as intimidating, and that's very true because of the stigma. And they think, sometimes when they come to my parents, say, "Oh, I thought it was an asylum. I thought it was a prison environment, or I thought I was sent there to be punished." So it's intimidating to some people. So difficult to get to. Sometimes some people want to avail themselves of the service, but they don't even have the money to, and to come, and then they may be living far away. So how do they avail themselves of those services? Too rigid or judgmental in their approach. Yeah, that could be a hindrance. And then irrelevant to an individual's immediate needs. Because people have various needs. And for some, they don't think the drug problem is their immediate need. And it may be too costly for some, particularly in my own environment where there's no insurance for people like that. You have to help them out, and get some funds maybe to reach out to indigent clients who will be able to access treatment. So our treatment methods and settings, community education with other agencies. As I said, we collaborate with different agencies in offering this kind of outreach services. And then talking with those who use substances at homeless shelters, HIV or other medical clinics, community centers, and drop-in centers. And the UNODC in Nigeria has actually helped us to be able to know all the treatment centers and the NGOs working in drug treatment, and then we have their own list, and we are connected. So when you are in a particular city, you know who is offering what, and then you can liaise with them, to provide these services. And then education and screening at schools, social centers, and clinics, and that is good. And many of the staff who work in some of those areas, we encourage them at least to undergo the UTC course or even the UPC course, and that is actually helping to improve the standard of care we offer to our own communities. Next, okay, other outreach efforts. Para-professionals can go where substance use is encouraged, such as dance clubs, and as I said earlier, we have those who live, in the bushes and in the hills. They go there. Most of them have criminal tendencies, and they tend to have a lot of confrontation with security agents. We have some people who have passion, who are able to reach them with their problems, and they're able to help them out. And that is very good. And we're working together. You have peer educators and visit places frequented by those who use substance, because they are in recovery. They know the psyche of these people. They understand them very well, and they can reach out to them without much ado. And medical staff can provide brief interventions and referrals wherever they work. Yes, that is very key. Screening purpose. Screening tries to identify only whether a problem exists and whether further assessment is needed. It's not trying to find out whether the patient has, the nature of addiction, comorbidity, or what. No. Is there a problem? Then what can be done about it? So if the patient has need for a further assessment, then they refer. But if not, they can just offer some counseling or maybe brief intervention, or just allow the client, the patient or the person to go, without necessarily going into in-depth, assessment. Yes. Screening tries to identify only whether a problem exists and what follow-up is needed. That is true. Is there need for follow-up? Yes. Assessment tries to identify as closely as possible the nature of an SUD and other issues and the level of intervention that may be needed. Yes, because if there is a problem, you look at many domains. You look at social problems, you look at other biological problems, you look at occupational problems, you look at medical problems, and so many other factors that may come in, and you take an in-depth history, and you do a comprehensive assessment before you can plan and say, yeah, this client has so and so problems, and I prioritize the problem, and this is how I intend to intervene. So assessment is a more in-depth method than screening, which is more or less superficial, then the first contact with the client. And validity of a screening instrument. Yes, the degree to which the instrument actually measures what it claims to measure. You cannot say you have a screening instrument and then you end up using an instrument ends up being a diagnostic one, because it will be more comprehensive if it's a diagnostic and more tedious to use. But screening just to tell you that there's a problem. But if you want to know the problem in depth, then you go further and assess. And there are internationally validated instruments. For instance, the audit. Alcohol use disorder identification test. It's a 10-item screening tool for alcohol produced by the WHO. So it's one that is commonly used, well researched, and is used internationally, across different cultures. So it's one screening instrument that's very handy. Then the alcohol, smoking, and substance involvement screening test, or the ASSIST, is also another one that's very good, and is also used cross-culturally in many settings, and it can help to know what the problems are. So other screening instruments, many other instruments have been designed for adults and adolescents. Some for adults and adolescents, and then if you use it for maybe for people who are maybe adolescents or maybe who are less than 60 years, it may not actually work for them. It's not be validated for such people. So you have to know whether it actually captures the age group that you are using it for, and then you can go to resource page 6.1 for additional screening instruments that have not been validated for use with all populations. There are many different instruments out there that you can use for different groups. But the ones that have been validated by the WHO and they are used cross-culturally are the ones I've spoken about, the audit and then the assist. So what does screening do? You screen. When you screen and you think the person has no or low risk, then what do? You just no further intervention. You can just congratulate the person and encourage him, to continue that way and not to take a risky lifestyle that may lead him into maybe having moderate or severe, particularly if there are family issues or genetic problems in the addiction or in the drug use. So you have to do that. But if there's a moderate risk, then you have to intervene. But the intervention doesn't go most times beyond brief intervention, which you can do once or you can repeat it, over time. And it doesn't take much time. You can do it in an outpatient clinic, even in the first contact, you can do that. So it helps. When you do that and you do brief intervention, it helps to give a feedback to the clients, and that ends it there. But if you think there's severe risk or a substance use disorder, you think there's a definite substance use disorder, then there's need for further assessment. You have to assess and then be able to diagnose the problem and also be able to prioritize and then plan for treatment and encourage the client, to go into treatment. Brief intervention focuses on increasing a person's insight into an awareness of substance use and behavioral change. Yes, that's what it does. And can be provided through a single session or multiple sessions of motivational interventions by ACD or other professionals, as I said earlier on. They just give them the feedback. You have a high, moderate risk, low risk, but I think, and then you educate them and tell them what they need to do and what they don't need to do. Brief intervention focuses on increasing a person's insight. Yes, we said it. And can be provided through a single session or multiple sessions by HCG or other professionals or even peer staff. You can train, most people can be trained to give brief intervention. There must not be HCG professionals, to be able to do that, but they can be trained to do it. It's easy, to do. I can do it in primary healthcare settings and also maybe even in a drop-in center, so on and so forth. Yes, please.
That's the last slide, Moses.
Oh, so thank you. Sorry for all the unnecessary interruption from the network and whatever. You don't see my face because my network doesn't allow me. Once I put on the slide, then it switches off the video. So because somebody asked, I don't see Moses' face. It's not that I'm hiding my face, but the computer is hiding my face, and I'm not also comfortable with it. Thank you for your interest. Thank you for the attendance, and we hope again to see you next time. But I don't know whether we'll have time for questions, whether Kim will allow us to.
We're over time. And it's my fault.
No questions, so we may do, but please go to our resource pages. They actually help you to understand what we have said, and then you go into more details, and it helps you to actually consolidate on what you have learned. They are very, very useful. Thank you.
So everyone, I'm sorry about my poor internet and the mess it made of the last half hour, but we will see you tomorrow, and I will, and if you have questions, go ahead and send them on the on that email chain, and we can answer them right away. And I will send out the link for tomorrow as soon as we get off. So thanks, everybody.